Welcome, everyone. We'll get started in just a minute as folks filter in. Good morning. Welcome, everyone. This is an Institute for Pandemics webinar focused on this question of, the WHO, the World Health Organization, has now declared that COVID-19 no longer a public health emergency of international concern. So what now? Webinar here today, as I said, is brought to you by the Institute for Pandemics. It's a cross University of Toronto initiative, but it's housed here at the Dalla School of Public Health. I'm Adalsteinn Brown. I'm the Dean of the Dalla School of Public Health, and I'm pleased to be here today with a group of our faculty who are going to be here to discuss what this means and answer some questions. But before we begin, I'd like to acknowledge this land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this is still the meeting place and home to many Indigenous people from across Turtle Island. And we're grateful to have the opportunity to work on this land. Now, just a couple quick housekeeping items. Please use the Q&A feature to ask any questions. Given the amount of time we have today and we know the interest in what's going on, we may not get to every question asked. And please know that the webinar today is being recorded and will be made available on the Institute for Pandemics website at a later date. So let's just start things off. For those of you who are sitting at a computer screen or on a mobile device, let's take a quick poll to find out what you are all thinking about COVID-19 right now. In a moment, a poll is going to pop up. There it is, asking you whether or not the World Health Organization declaration for last month really does signal the end to the COVID-19 pandemic. Answer yes, no, unsure, but we'll use the poll results here to just sort of set ourselves up for a bit of discussion. The poll is closed, and you can see that about 1 in 10 folks think that this does mean the end of the pandemic. A little bit more unsure kind of what this all means as we cope with it, but the overwhelming majority of folks would say, no, this doesn't mark the end of the COVID-19 pandemic. Okay, that's a good setup for us as we move into our discussion. And it gives me a lot of pleasure now to introduce my colleague, Dr. Fahad Razak. Fahad is an internist and epidemiologist, and his research focuses on improving the care of hospitalized patients through the application of advanced analytics to hospital data and other sources. He co-founded Gemini, the largest hospital research network in Canada. And it's one of the few examples of such a network globally. And he was, where he and I worked most closely recently, the scientific director of the Ontario COVID-19 Science Advisory Table, which provided briefs and updates throughout the COVID-19 pandemic. While he was there, he co-authored or led more than 40 science and policy briefs that helped shape a number of aspects to the response and public understanding of the pandemic. With that, Fahad, let me turn it over to you, please.
Thanks for that kind introduction, Steny. It's a pleasure to speak to all of you today. I'm just going to start with a summary of where we're at currently with this declaration, what it means, and how that's going to translate to our next steps, I think, here in Ontario and in Canada. Just want to confirm everyone can see the slides. Looks good. Okay. So this will be a brief presentation just to kick us off, and then we'll be moving into the discussion part of the presentation. So as we have now passed the 3-year mark of the pandemic, and as we're into the 4th year of the pandemic, this declaration, I think, is an important moment to recognize both what we've achieved, where things potentially could have gone much, much better, and then what the next steps are as we move forward. So just briefly, I'm going to cover what this declaration means. The specific technical term is a public health emergency of international concern, or sometimes called a FIC. Why did the WHO end the FIC at this 3-year mark, and what are the implications for Canada? So first, what is a public health emergency of international concern? So under guidance from a committee of the WHO, the International Health Regulations Emergency Committee, the WHO, specifically the director, can declare a FIC if a health condition has the following properties. First, if it's an extraordinary event. Second, if the public health risk extends to states and has the potential for important international spread. And then third, potentially if it requires a coordinated international response. So these three criteria were met back in January of 2020, and the COVID-19 pandemic was declared a FIC. And then it was now ended 3 years later in January of 2023. This declaration, once it is set, is temporary and requires a renewal every 3 months. Over the last decade, it's important to recognize that there have, in fact, been many conditions that have required the declaration of an emergency. So here are 7 conditions, at least, here are 7 conditions over the last decade, including the H1N1 swine flu pandemic, the polio declaration back in 2014, the outbreak of Ebola in Western Africa back in 2013, the Zika virus epidemic, a second Ebola epidemic, and then the declaration of the COVID-19 pandemic, which we're discussing today, and finally, and most recently, the Mpox outbreak. So on May 5th, 2023, the WHO International Health Regulations Emergency Committee advised the director to end the FIC. The director did go ahead and end the FIC. And these were 2 quotes from that recommendation statement. First is that COVID-19 is now an established and ongoing health issue, which no longer constitutes a public health emergency of international concern. And second, it is time to transition to a long-term management of the pandemic. So importantly, you'll see here that it was rather than declaring an end to the pandemic, it was really about the mentality that we need to adopt going forward, which is one of long-term management, adaptation, and proactive management rather than that crisis response. So as the fight comes to an end, and similar declarations have been ended through many jurisdictions, I think it's an important opportunity to look back to see how we did as a country and potentially where we could have done better, and then to look towards those next steps. So if you look at Canada specifically, our health outcomes and public health outcomes were better than many comparable industrialized nations. So for example, if you look over the first 2 years of the pandemic per capita, we had 70,000 fewer deaths here in Canada versus the United States. And again, that's on a per capita basis. 70,000 fewer deaths obviously is an enormous number. That means that most of us probably personally know someone who is alive today that would have died if we followed the US course. If you look at, for example, infections, we had 9 million fewer infections per capita versus France over those first 2 years. We know, for example, that those early infections, especially before a vaccine was available, had a much tighter link to the development of long COVID. Many of those infections were incredibly disruptive. Even if they didn't lead to deaths, they led to prolonged hospitalizations and disability. They led to disruptions of schools, of workplaces, of family events. And so 9 million averted infections in those first 2 years is considerable. We also had considerable health system rallying in the face of this pandemic. So we entered the pandemic with one of the fewest per capita acute care beds among any OECD country. That was what led to things like hallway medicine even before the pandemic started. But we were able to maintain capacity through extraordinary steps. So we saw the transfer, for example, here in Ontario, of more than 5,000 acutely ill patients between hospitals, something that's never occurred before in this province. And we were able to avoid some of the worst outcomes that we saw in places like Lombardy, Italy, or New York City, where they had essentially near collapse or collapse of the hospital sector. We also achieved the highest primary series vaccination rates in the G10. And this was especially incredible considering we had one of the most delayed accesses to broad vaccine availability among G10 countries. So we had relatively slow access, and then we saw this rocketing vaccine campaign. And a lot of it was through these extraordinary steps like community vaccine clinics, taking vaccines out to buildings where people were less mobile, going into lower income or marginalized neighborhoods. So you saw really a rallying and coordinated strategy, which was very, very impressive. And of course, the scientific developments. So if you look at the development of a vaccine itself, many vaccines to illnesses took decades to develop, but we saw here in SARS-CoV-2, the development of a vaccine in less than 12 months, truly a remarkable achievement for human science and ingenuity. So again, there was much to praise over those first 3 years of the response. However, it's also an important time to reflect on the incredible destruction and disruption that occurred. So starting first with deaths, Canada experienced more than 50,000 deaths from COVID-19. Just to put this in context, that's more deaths than, for example, occurred during World War II for Canadians. And we had one of the highest mortality rates among long-term care residents of any comparable wealthy country. By some estimates, during those first waves, more than 70% of all deaths occurred in long-term care residents. There was massive disruption to the health system. So there was declines in everything from cancer screening to routine vaccinations to elective surgery. We're still playing catch up in many ways. And the Canadian public experienced some of the strictest and longest public health restrictions among any comparable country. Especially important to note, we had prolonged closure of things like schools during the pandemic, longer than many other countries. And we had significant economic and social disruption, school and business closures, and then a marked rise in polarization. So the WHO now recommends 5 areas of coordinated strategies as we move beyond this emergency phase of the pandemic. Again, this is not the end of the pandemic, but one really a point of stable, proactive, adaptive management. Those 5 elements are collaborative surveillance, community protection, access to countermeasures, safe and scalable care, and all of that coming into a coordinated response. And here's the specific recommendations that accompanied the end of the declaration from the WHO, and I think it'll be an important launching point for our discussion today. So the specific recommendations that the WHO made for countries now going forward is to sustain a national capacity to and the gains that have been made these last 3 years to prepare for future events. So specifically, avoid these cycles of panic and neglect, incorporate the learnings from national and subnational after-action reviews, so specifically pointing for the need for an after-action review, something that has not happened yet in Canada. Integrate COVID-19 vaccination to the life course vaccination program. So rather than these extraordinary community events in stadiums and malls, have it part of our routine delivery of care. Bring together information from a diverse respiratory pathogen surveillance data to allow for comprehensive situational awareness. And this can come from multiple sources, things like sentinel surveillance, serosurveillance, and a One Health approach with animal surveillance. Work with communities to achieve strong, resilient, and inclusive risk communication and management. Again, something that I think Canada showed real potential for what can be gained by doing that early in the pandemic, something that we need to sustain. Continue to lift COVID-19 international travel related health measures. These were done with good intention earlier in the pandemic, but have been found in many scientific studies to be non-effective and potentially discriminatory. And then finally, to continue to support research, improve vaccines that we have, move towards a universal vaccine, things like intranasal vaccines, understand the full spectrum of disease, the incidence and impact of COVID-19, and especially the impact on susceptible populations like the immunocompromised. They also highlight the importance to develop a long COVID strategy. And then finally, develop integrated care pathways where COVID management is part of that comprehensive management plan in the health system. So I'll turn it back to Steny now for our panel.
Thanks, Fahad. That's great. Let me now introduce the rest of the panel. I'll start with Dr. Nelson Lee, who is the Interim Director of the Institute for Pandemics. Nelson is an infectious diseases physician, has been deeply involved in research on emerging infectious diseases, epidemics, and pandemics for now almost 2 decades. I'll turn then to David Fisman, who's the lead of our Readiness Theme. He's a physician and epidemiologist who studies the epidemiology of infectious diseases, but not only COVID, a lot of work on pneumonia. Next would be Dr. Sara Allin, who's the lead of our Resilience Theme. Her research focuses on ways to improve health system performance and really helps articulate a number of comparative ways of understanding performance across provinces and territories and other countries in healthcare and public health. And finally, Dr. Geoff Anderson, who is the lead of our Recovery Theme. And his research focuses on health outcomes in high needs and vulnerable populations. He's got deep experience in international comparisons of health policy and outcomes. If the panelists would come on screen now, we'll kick it off. Nelson, maybe I can turn to you first.
Well, thank you, Steny. I'm just going to make a few quick points. I want to echo what Fahad has said. Stand down of the emergency measures does not mean that COVID-19 has disappeared. No, the pandemic is over. But it's definitely slowed down. According to the WHO globally, there are still more than 1.5 million new cases and over 7,000 deaths just in the last 30 days. And there's a lot of underreporting, meaning that there's significant disease activities across wide geographic areas. That therefore is still a pandemic. And based on what we have learned so far, I think that it's very likely that COVID-19 in the near future will circulate in the community continuously and therefore becoming endemic, but with the ability to cause periodic outbreaks and therefore epidemics, resulting in excessive hospitalizations and deaths as the virus evolves over time. And the situation is very similar to influenza. The 2009 H1N1 influenza pandemic virus is still around, is still causing infections every year until now. For COVID-19 in the past 2 years, so it's possible that the interval between epidemics is shorter and therefore a bit more frequent. I'm making this point to clear possible misconceptions that pandemic is now in the rearview mirror or COVID-19 has totally disappeared, and therefore vaccines, testings, and treatment are becoming unnecessary. I think that is not true. We're transitioning into the next phase, and we must remain vigilant. Secondly, I wish to point out that COVID-19 disease now looks quite different and exists in many forms. And obviously, there are fewer deaths related to direct viral infection, but there could be a range of medical complications in patients' lungs, heart, brain, digestive diseases, causing blood clots, diabetes, exacerbating patients' underlying conditions, and some may suffer from long COVID symptoms. And there could be medical consequences related to multiple episodes of infection, which we're just starting to learn about. The most affected ones would be the older adults, those with underlying conditions, immunocompromised, and the less resourceful ones. So we must continue to protect the vulnerables in our community. Thank you, Stanley.
Thanks, Nelson. Maybe I can go to you next, David.
Sure, and thanks for the great presentation, opening remarks. I mean, to me, not to be Debbie Downer, but what's remarkable, I agree with what the WHO has done in the strict sense. What we have is we have a disease that's gone from multiple, simultaneous epidemics worldwide, that is the definition of a pandemic, to a disease that's now in many places endemic. That means the reproduction number is around 1. So each old case replaces itself with a new case, and we have a steady level of infection. I'll depart a little bit from what Nelson suggested in terms of this being like influenza. Influenza has a much lower reproduction number, and we have a lot different level of population immune experience with influenza. What that translates into is influenza is a seasonal epidemic disease. What we have with SARS-CoV-2 right now is a hyperendemic disease, which is there all the time. It's a highly virulent pathogen. As Nelson pointed out, it causes multi-system infection. It's basically a virus that affects blood vessels. And in as much as, when we have inflammation of a blood vessel in medicine, we call that a vasculitis. And we talk about vasculitides often as great imitators in medicine. And that's because you got blood vessels everywhere in your body. So this is a terribly dangerous pathogen, which I think via economic imperatives, we've decided that we need to move away from aggressive public health control, but rather than take this problem on its own terms, use the information we have to actually solve the problem. What a lot of societies, including ours, have elected to do is simply to package this as no big deal. It's over, don't need to do anything about this now. It's just, it's background noise. And that's not true. I think when I look at the WHO recommendations, what's striking about those is this almost almost an ideological refusal to learn from failure. The Lancet COVID Commission had identified a number of failings in terms of the initial pandemic response. Very few of those are acknowledged or addressed in the WHO's remarks in terms of how we move forward. The issue of changing physical environment, indoor air, just as we did with sewage 120 years ago so that we don't drink poo, we actually have the tools to remove this virus and other pathogens from the air. That's not there. There's no real acknowledgement of disinformation as a major factor that aggravated this pandemic. I mean, Fahad mentioned polarization. That's very true. We have sort of this crisis of legitimacy that's come via disinformation, but there doesn't seem to be any disinformation strategy there. And, and lastly, I think in terms of internationalization and information sharing, I don't think it's lost on most countries that the countries that played ball during the pandemic in terms of timely sharing of good scientific information, if they were poor countries and not white countries, they got punished. And you saw that to the max in terms of Southern Africa's identification of Omicron, at the same time as Omicron was circulating in the United Kingdom and the Netherlands. And what happened? The South Africans reported it first. The South Africans got the travel bans, not only the South Africans, but a number of other African countries. Meanwhile, the Netherlands and the UK neither had a travel ban, despite having, the same epidemiology and just not having played ball. So I think we're coming out of this pandemic with the response not simply having been imperfect, but there are aspects of that response that actually make it much more difficult for us to respond next time, because not only was there an unwillingness to learn, but the folks who played by the rules actually got punished, and I think people have noticed that.
Thanks, David. Sara, can I go to you next, please?
Sure. I'll try and express a little optimism, though it's challenging at this time, as we've been through so many years of this challenge cross-cutting our society. But I'm really happy to be on this panel, share some reflections as the lead of the resilience theme of the Institute for Pandemics. And we talk about resilience a lot more now than we used to, not surprisingly, but what does it mean? It's a term that sort of has become all-encompassing, but really it is refers to our ability as a health system or a society to prepare for and anticipate, to adapt and respond to, and really to learn from the shocks and stressors that we face, such as pandemics, economic shocks, but also the acute and chronic effects of climate change. And so a resilient system would be one that minimizes the negative consequences of the disruptions. And so Fahad spoke really well about how the health systems in Canada responded in some ways quite well to minimize these effects of COVID and to try and recover as quickly as possible. But also what's critically important in understanding resilience is how are we able to adapt and improve, learning the lessons from the experiences of the shocks to be better prepared for future pandemics and emergencies. And so along the lines of what David was saying, like, are we learning? Are we better prepared, or are we, positioning ourselves to face more negative consequences in the future? Is something we are really interested at the Institute for Pandemics, and something that we think is critically important. As WHO ends its declaration, I mean, there's a real risk globally and in Canada that will sort of passively kind of return to the baseline, what we had previously been focused on in our efforts to, reform the health system, to continuously improve it, but without this recognition of the experiences we've all shared and how do we learn from those and really embed this thinking about resilience in all aspects of our health system reform and strengthening efforts. So we see, during periods of shocks, there's a huge investment a huge collective will and mobilization and public health spending that we see increase to really address the shocks and to respond in a way that is as effective as we can muster at the time. But then we see a huge bust in that funding. A boom and bust cycle is often referred to. And I think Fahad mentioned the panic neglect cycle. It's a similar kind of idea where we are, we're really proud. We did very well in mobilizing and responding as well as we did. However, our memories are very short. And so as a researcher in health systems, I'm really actively involved in work that looks back at how things have gone in Canada. And what's striking is that there have been few formal inquiries and reports that have come out taking stock on what happened. So there's been a few targeted commissions. For example, in Ontario, we did have a commission on COVID-19, the long-term care commission in this province. And then other provinces have also had some targeted commissions, and auditor generals have looked at how money has been spent. But there has been no broad sort of commission or inquiry that will allow for all the lessons to be compiled and put together in a single place. And I hope to be able to contribute to something like that to prevent, at least we would be able to document and then be able to refer back to how well or not we learned. And from our experience in past pandemics and epidemics, I think we have a lot to worry about in terms of our collective ability to learn and improve and to build back better after shocks. But we can still hope that the research that we can contribute to and provide records that can be referred to in terms of the variations that we saw within Canada in terms of how well we responded and how well we mobilized and addressed inequities throughout the pandemic, but also globally, will be an important area for us as a society. So I'll leave it at that, and I look forward to contributing to your Q&A broadly.
Thanks, Sarah. Geoff, you're next, please.
Thanks a lot, Stani, and thanks to my fellow speakers. So I'm Geoff Anderson. I'm leading the recovery theme, and I'm actually co-leading with Simone Vigood, who's a psychiatrist, and Shauna Braille, who's an economic geographer and based at the University of Toronto, Mississauga. And the ideas I'm expressing reflect the work we've been thinking over the last 2 or 3 years around the pandemic. So our theme is focused on what we call the broader health impacts of COVID. So we're not focused on long COVID. Long COVID is incredibly important clinically, affects a lot of people, but there's lots of other people working on that. That's not where we're focusing our efforts. We're focusing our efforts on health impacts of pandemic and pandemic containment on other facets of health, not the infection itself, but the broader impacts. We're really focused on health inequities, an issue that Sarah just referred to. And we want to be able to move forward to think about how we can build back better and fairer, because the term recovery means that we are making efforts to improve what happened. Well, let me begin by saying we did some heroic things during COVID, and people on this call made some very tough decisions. Those decisions are tough because they come with risks. That's what makes a decision tough. And I think we have to look at some of those risks and how they played out in this province. So I'm going to try and make 2 brief points. One is that, as Fahad indicated, Canada had lots of stringent restrictions. Ontario was actually more restrictive than a lot of other provinces. So Ontario had some very intensive restrictions. And I also would say that, as he pointed out, we know that there's socioeconomic and economic social disruptions caused by those efforts to contain the pandemic. So I'm going to try and make 2 points based on that. One is that we should think about the impact of those on existing health inequities. And the second is that we should have concerns over some particular populations that we think were affected during the pandemic. And those concerns, both of those concerns, are rooted in sort of my interest in population health, which is the notion of basically why some people are healthy and others are not. And it's true that genetics makes a big difference. It's true that noxious agents and infectious agents make a big difference. But we increasingly realize that social and economic circumstances are major factors in making some people healthy and other people less healthy. And that's an important thing to think about, so that you can think of this cross-sectionally. So, COVID was supposed to be the great equalizer, right? It affects everybody equally. It turned out to be the great revealer of health inequities. That cross-sectionally, if you were in a lower socioeconomic status or in a socially isolated group, the pandemic, the infection affected you more than other people. So that's sort of the cross-sectional thing. What's, I think, more compelling to us right now is a longitudinal impact. So we know that pandemic affected socioeconomic and economic and social features. And what are the consequences of that? And it's important to understand a lot of this is relative. This is not just rich country, poor country. Michael Marmot did some foundational work in the UK showing huge health gradients across civil servants. So it's not just super rich countries and super poor countries within our own country. So what happened during the pandemic? We think it disrupted the economy. We think it made economic inequalities greater. So one of the consequences that we need to think about is, what's the impact of that on health? What's the long-term consequences of greater social inequity on health inequity? So that's one. And the other, I think, is a bit more direct, is there were some groups. One of the things we learned is that the most vulnerable people to socioeconomic and material deprivation are children. That's why we have early education. That's why we support mothers of young children, because we know they need supports at that point in time. And there are, I think, legitimate concerns that the disruptions during the pandemic had adverse effects on mothers of young children and on children. And those are going to have long-term consequences to health. And we've done some work showing that the mental health visits for mothers of young children went up 20 or 30% during the pandemic, stayed up for 2 years. We know that kids, mostly, to be honest, mostly adolescent young women and adolescent women, mental health utilization went up a lot during the pandemic and stayed up for 2 years. So we have people whose formative years have been changed. So I think one of the issues there is sorting through that in the future. And our final thing is, let's build back fairer and better. I think we can start to do some things. We need to focus our efforts on those people. What happened to those children who didn't get the contact that they might have gotten during the first 2 years of life? What happened to school kids who missed basically 2 years of in-person teaching? What can we do to help those? I think there's positive things that can come out of this in terms of decreasing social inequities and sort of responding to the needs of vulnerable populations, particularly young children. Thanks.
Thanks, Geoff. Okay, so we've had a whole bunch of questions submitted during and actually before the conference. So I'm going to maybe start with an overall question, and then feel free, anyone, to kind of answer this. What do we want to see actually kept out of this period of time? Everyone's talked about the interventions. Everyone's talked about how a lot of them kind of disappeared. Now, what would we want to keep from this period of time? I would like to start.
I can start, Saini. It's such a great question. I think there's a lot of things that we would want to keep. One of the things I mentioned is the ability to really invest in our health system and society really quickly. We were able to do that. I think this is something that we can continue to do. We don't want to now hold back and worry about the healthcare system as a cost. We should consider it as an investment into our future and our resilience and our sort of broader population health. So that's something to keep, perhaps. And then the other thing that I think that really struck me as the sort of rapid mobilization in the response to COVID-19, at least in the province of Ontario, was to try and create a system where we didn't have one. And one of the examples is around COVID testing, where all these different players in the health system, including public health and hospitals and the newly formed agency, this sort of super agency, Ontario Health, work together in new ways that relied on information being shared across these groups that never had before, setting up this super rapid system really to ensure that all Ontarians in need could get this COVID test and use this for surveillance, but also clinical purposes. So that's something that, creating a system out of one that previously did not exist is something that I think could be built upon and scaled up to other aspects of our system, and to address fragmentation and the lack of sort of integration that we have persisting in our systems in Canada.
Thanks, Sarah. Anything else that we want to keep out of this period?
I'll go next.
Go ahead, Chris.
I think that I would say community testing and surveillance. Previously, we were able to track the growth of pandemics and even forecast the trend. And now with such testing, modeling, it's becoming more challenging to detect the imminent arrival of the next wave. Wastewater surveillance is now shown to be a valuable tool, but we do need more innovative methods and solutions to help us to track the epidemics in multiple domains across our community and in certain sentinel groups. So we've got to be innovative and keep this going.
Okay, Fahad?
Yeah, I'll just add briefly to that we clearly had very significant data gaps going into the pandemic in our health system fragmentation, and they weren't nearly fully addressed during the course of the pandemic, but we did see some innovations, and we saw, I think, how the connectivity and rapid access to data could drive smart policy. So I'll just give one example. Looking at where the highest burden of infections was occurring relative to where vaccines were being deployed allowed us in Ontario to pivot our vaccine strategy in a way that was really outside of what is typically done. Vaccines are normally prioritized by very simple age-based criteria. We were able to prioritize neighborhoods of highest risk. We were able to demonstrate that strategy would not only benefit people who live in those communities, but would benefit the system overall in terms of reducing illness. And importantly, that data was not just data by itself. It was used in partnership with community groups to help us figure out, the last mile challenge of getting the vaccines to populations that are difficult to vaccinate. And I think part of what drove that initially very high vaccination rate, the highest in the G10 for the primary series in Canada, was the combination of all of that. It was the breaking down of certain data silos, the smart analysis and link to policy, but importantly, real partnership with communities to get the vaccines out to those who were harder to access and who would benefit the most from those vaccines.
Let me shift gears. So we've seen the end of formal protections for folks. We've lost this sort of collective sense of emergency. But the virus there's a lot of folks who are incredibly vulnerable to this. What do we do to make sure that we're protecting or supporting those who are most vulnerable to this, even as we come out of this state of emergency? That vulnerability hasn't left.
That's a problematic framing, right? And this has been sort of from the Great Barrington Declaration on forward, this notion that you can cordon off some in the population, separate them from others, and will do a great job of protecting. Never mind the data that show what an absolute slaughter went on in our long-term care facilities. We clearly didn't do that. But I think that framing is really damaging because it creates the impression, which is incorrect, that a society is separable into little units that can have tenuous connections to one another. What we need to do, we've always, as far as I know, I'm not aware of a communicable disease epidemic that hasn't disproportionately impacted people with less social and economic resources than more social and economic resources. I'm a little bit fixated on cholera just because it's very interesting history in terms of how that challenge was actually met. But you saw that during cholera in the 19th century, poor neighborhoods were hit much harder than rich neighborhoods. Ultimately, cholera ceased to be a threat in high-income countries because we built infrastructure that protected everyone. We treated our water and we treated our sewage. I differ from Geoff a little bit in terms of his characterization of public health controls. Because you say, well, the kids had issues with schools being closed. I mean, there are problems with those data, and in fact, some kids had issues and some kids did better. I think we had a bit of a moral panic around school closure. There's a marvelous article about that by Tyler Black in Canadian Journal of Child and Adolescent Psychiatry right now, if you want to check that out. But that said, the reason closure of schools impacted mortality is because kids are connected to other kids who are connected to adults, who are connected to grandparents and so forth. And I think when you get into this sort of discussion around mental health, well, you know what's really bad for mental health for kids is losing their parents. We have 7 million COVID orphans on planet Earth that we didn't have before this thing happened. That's bad for kid mental health too. So I think that the big failure, right? You have the emergency measures, you pull the fire alarm, you do stuff. You know, when the fire department comes and sprays water on your house, you don't say, "I'll just spray on this side because that side's got my good stuff in it. I don't want you to get that side wet." What you're doing is you're putting out the fire. But what you do after the fire is out is you learn and you build and you design things so that you don't have another fire. And that, to me, we have basically laid out how to prevent respiratory infectious diseases. Influenza went extinct. In fact, we have a bee lineage that hasn't even come back. It's legit extinct. Respiratory syncytial virus went extinct. We didn't have any group A strep sepsis for about 2 years in critical care in Ontario. Streptococcus pneumoniae went extinct. We actually have demonstrated to ourselves that respiratory diseases are optional. Now, we're obviously not advocating moving forward by everyone being masked all the time, but masks prove to be a very useful tool in a pinch. And we have other devices and other technologies that we can use to do what masks do without us having to wear masks. And those mostly relate to cleaning indoor air so that these diseases, if they emerge, have a reproduction number less than 1 and fizzle out. So there's a lot on the table in terms of how we improve indoor environment. It's all about equity, because the people who died 5 times more in Canada were poor and Black. That's a big effect, a 400% excess in mortality in poor Black Canadians, and that's unacceptable. But we do have the tools. The question is, are we willing to learn from what's happened and start investing and applying those tools, which will be money in the bank in the future? As Fahad showed when we kicked off, it's kind of like the climate change thing, which is mentioned. You can't call them 100-year storms if they're happening every other year. We have exceptional public health events now happening every 18 months, right? So if you want to design these things away, we have the tools, but we actually need leadership, and we need communication, and we need effort, and we need investment.
Okay, let me hold there, and we're starting to get close to the end of the time, so maybe short answers. We'll get through some more questions. Fahad, you're next.
Yeah, I'll just, as I was listening to your question, stating into David's response, I was thinking about Jeffrey Rose, one of the great kind of theoreticians of public health, that drew these lines between what we consider to be sick individuals and sick populations. And there's a real opportunity for a sick populations conceptualization moving forward. And then I think a great example of that is indoor air quality. So this is something that will benefit all of us, some more than others, but all of us will derive benefit from improving air quality in a way that I think David pointed to our approach to water quality, over the last century. And so there's an opportunity to think not just about COVID and influenza and other respiratory viruses, but cognitive improvements that would come from improved air quality. So there's a lot of applications. And I'll say, just in terms of high-risk populations, one of the things that I found very discouraging was the fall-winter 2022 season with respiratory viruses in children. That was 3 years into the pandemic, and we saw this incredible surge of respiratory viruses predicted, in many ways manageable, better than we had the willingness to manage in terms of masking in schools, access to therapy like antipyretics for children. And there's a recent paper from researchers at the Dalla school that showed that during that period, there was a doubling of unintentional poisonings of children of Tylenol and Advil during that period, because parents were so incredibly worried about their kids. There was no medication available. There was these surges of viruses that they were cutting up adult doses to try and prescribe to their children. So you saw these extraordinary steps and these negative consequences. And I was hoping to see 3 years in the pandemic that we wouldn't be in that kind of situation.
Great. Geoff, we'll go to you next.
So just a couple of quick comments. One, this whole conversation has been built on the theme of social inequities. And I think one of the things about resilience is one of the things that's going to make our country and every country more resilient to pandemics is decreasing the socioeconomic gradients. They're at the highest they've been in 80 years. It's like we're back to the Gilded Age, right? So that there's huge inequities in social opportunity and material opportunity across our populations, probably larger than it's been in years. So I think we all recognize that the socioeconomic inequities are big drivers of the impact of these diseases, and the idea of targeting everybody and targeting those who have most to benefit is an interesting conundrum. But I think one of the things we can all do to make a country more resilient is decrease social inequities. The other one is like David, of course, I'm going to have to respond to the thing about the school closures. You can make an argument that school closures had impacts. Of course, you can make that argument. But to be honest, other countries who have scientists that are just as good as us didn't close schools at all, right? Japan never closed schools. Sweden never closed schools. France never closed their schools. So that's a decision that was a tough decision. And all I'm saying is that it wasn't a cut and dried math problem. It was one that built on lots of things. We made a decision on one side, and I think it's worth looking at the consequences for kids. I mean, all of us, most of us here had kids that were at school that changed their lives. It changed lots of people's lives. We have hard evidence that it affected lots of fundamental interactions, and that kids are having mental health issues, right? So, we need some balance in this. When you make tough decisions, you have to be able to look at them carefully. So again, this gets back to the idea of there are consequences to your decisions. And I would say that we made decisions to protect old people like me. And part of that cost was borne by children and mothers of young children, right? Who weren't going to get the disease, but their lives were fundamentally changed to protect people like me. So I think that's worth looking into.
Okay, I'm going to shift us now to a slightly different sort of line of questioning. Thanks, everyone. Masking. So there's a lot of questions that came in from registrants about masking and what we should be doing about masking as we move through the summer and now into the fall and winter. Who'd like to start off with some thoughts about masking? David, go ahead.
Sure. I think the benefits of masks have probably been a little bit underplayed. When we circled back early in the pandemic, we had looked at Ontario did a very interesting thing in summer 2020, which is that we didn't have great leadership coming from the CMOH's office on the question of masking. And local medical officers of health, of which there are 34 in Ontario, some got impatient and introduced indoor mask mandates. And they did it in a kind of quasi-random fashion across the province. And that actually set up a really interesting quasi-experiment, which has already been looked at by a group of economists, and they find about a 20% effectiveness in masks, in that community mask mandate, which is not masks per se, because some people aren't using them, some people are using them wrong, and so forth. When we circled back, we had done a project early in the pandemic looking at the impact of under-testing younger people on how we see the pandemic, because our testing was very focused on long-term care. So if you look just at crude case numbers in Ontario, it looks like the epicenter is in 80-plus-year-old women, because that's the majority population in long-term care. That's who got over-tested, and to some extent, younger women who are the majority in healthcare work. Once you adjust for that under-testing, not only do you see the pandemic very differently as something that was much more strongly driven by young people, particularly young men, but you also can then relook at the mask data as the economists did. And what do you know? Once you're looking at young people, you don't get 20% efficacy, you get 50% efficacy or 75% efficacy, depending how you do the model. So I think one of our difficulties is disinformation's been very focused on masking. There's been a lot of manufactured concern around masks things like gas exchange and healthcare workers. We used masks for surgeons and masks all day in the OR. We never really talked about this until this became a political issue. I don't want to be masked all the time. I still mask when I'm in indoor spaces. I use a well-fitted respirator and I feel very safe. But I think as a society, again, we need to realize that masks are a stopgap. And what we need to do is actually focus on how we change indoor air so that we don't infect each other when we're sharing air. It's really as simple as that. And I think until we actually try to counter some of the disinformation that's out there, and I think the healthcare community has sometimes aided and abetted that. Raised all kinds of concerns about masks that nobody was talking about in 2018. If it wasn't an issue in 2018,
let me let Fahad get in there too.
I think that's held us back.
Great, Fahad.
Yeah, I'll keep it very brief, and I'll just say that I hope we can move to a state where masks are less politicized and more part of a comprehensive response strategy. They clearly have a role in a targeted way, especially during periods of respiratory viral spread. You see from a behavioral perspective that this can be achieved in East Asian countries without nearly the politicization that we have here. I think they would have an important role. And I'll just say that the only two Canadian polls, national surveys that I know of that were done late in 2022 around the time of the pediatric surge suggested that 70 to 80% of Canadians actually do support masking in public, crowded indoor settings during limited periods of enhanced viral spread. So I think most Canadians do see this as part of a comprehensive strategy.
All right, let me go to what's probably going to be our last question. I guess it'll be something that everyone's going to want to comment on. So, we've gone through repeated public health sort of crises. We're thinking about COVID, we're thinking about SARS, thinking about MERS, but we always seem to have kind of a bit of a collective amnesia afterwards. We maybe write some reports, maybe there's inquiries, there's been some very limited ones so far. What do we do to make sure that we don't sort of find ourselves on our heels again, that we're not unprepared once again for the pandemic? Who'd like to start? Just a small question. Geoff, why don't you go first?
Okay, I'd just like to pick up on the theme that Fahad raised. I think we need to have in place the data that is required to keep track of the pandemic. And I would say in that context that we really need to understand the socioeconomic and community level factors that are related to that. So the idea of being able to understand how diseases spread and how therapies can be rolled out depends a lot on our understanding of different communities and be able to engage with them in new ways. So building on the theme of sort of get the data, have it ready when we need it, and build those relationships with those communities so that when we need to access them and their data, we have the understanding and their commitment and their engagement in using that data.
Great. Who wants to go next? No one wants to take this one on? Okay. Fahad, go ahead.
Yeah, I mean, I think you've heard today that a lot was achieved through kind of collective action and these linkages between the scientific community, the policy community, and importantly, the public in working towards that common goal. We have clearly lost that on all fronts over the last year. We've had kind of a breakdown of that public government partnership. There's less of that scientific advisory directly into policy. And so I think part of an important response going forward is trying to strengthen those ties in a non-politicized way. I realize many of these things became very controversial, but what you saw in Canada was the ability to rally collectively and achieve really something very significant over those first couple of years. And I hope we're able to move towards that going forward, because it will be at the core of any future pandemic response or the ongoing response to this pandemic.
Great. Thanks, Fahad.
Yeah, I just want to jump in, Stanley. I think that we are still in the midst of a pandemic, but we should be really thinking about pandemic preparedness in the coming months and years, because it's very possible that we are going to have another wave or or another pandemic. The question is just when. So I think that Canada has made some key investments on how to get the tools and the structures ready to prepare for it. We need the ability to respond quickly to new pandemics in its birds with strong, precise measures. And we know that jurisdictions that can take strong early actions against pandemics were also able to keep their economies more open. So alluded to what Geoff has spoken, we need a better information structure. And also we need clear guidance on how to keep different sectors of our economy and society operating safely. And if we want to minimize closure of all sorts, we need to better understand how infections transmit and the ways to prevent it, including what some of our speakers had mentioned, indoor air quality, and to build system resilience and the right infrastructures going forward. Thank you.
Okay. Sarah, any thoughts from you on this? You look around systems around the world.
Yeah, I think I lost track of your question, Steny, because I've been trying to follow the chat, which has been super engaging. But in terms of, where to go from here,
to make sure that we don't suffer the same collective amnesia that we seem to after every public health crisis.
I think we will, and we already are suffering the amnesia. But in order to wake ourselves back up, then perhaps we need to do more on public communication, more on public trust and engagement. This can happen locally with the model that we have in Ontario is unique in Canada with boards of health that have public participants and open sort of records of discussion. This is a model that could be used at other aspects of decision making, both provincially and nationally, that we do not have that level of transparency and sort of public involvement. So I would say that, increasing we can trust the public to tackle difficult and to really, understand the challenges that the decision makers face and that these are not easy decisions. I think we can empower the public with more information rather than trying to shelter them from these difficult decisions. So I would hope that public trust is a way to improve resilience to the future, and to wake us up. We need to have more engagement, more public communication, and consider the different ways in which we communicate with different populations. So keeping equity at top of mind with communication engagement strategies.
Great, thanks, Sarah. So we're down to just a couple minutes. I think another round of questions would probably take us well over the 12 o'clock mark. I'll just remind folks, if you can see on the chat, we've got a Twitter handle, we've got a LinkedIn handle. We'll let folks know through those vehicles when the recording the session is up. I'll just take a second to thank all the panelists here today for talking about this. You can see why the Institute for Pandemics is an important part of what we're doing here. And hopefully we'll see everyone who's joined us today, over 250 people, at our next event. Thanks, everyone, and have a great week.